All right, everyone. So we'll get started on chapter 27. This is over bleeding. This is an interesting chapter. One thing I'll just start off with is um, I've trained a lot of five to 7,000 people in Stop the Bleed in Parker County. And so what's important is in the comments of this video, I'll link our Stop the Bleed video. And then for our students in class, you'll become a Stop the Bleed instructor. We'll put you through a full Stop the Bleed class and make you Stop the Bleed instructors. So you can go out and teach, the true Stop the Bleed course to the public. So this is kind of supplemental. This chapter will talk about bleeding and hemorrhage control, but it tends to focus on some of the pathophysiology that is obviously commonly tested because this is a very serious complaint and thing that we encounter in EMS is bleeding. So we'll talk about what it is and what it isn't. So bleeding is obviously a very time sensitive condition, and so if someone the chances of someone truly bleeding out to death isn't as common as the movies would make us think. I'll say that. But what does happen is blood loss will obviously harm the body. And so you lack perfusion to the kidneys or to the brain or to the heart or the lungs or wherever. And so, this is kind of the consequence of that is yes, you could lose a couple liters of blood and likely live eventually. But what was the consequence of that? Like, yeah, they live, but now their kidneys don't work, or they have brain damage or whatever. And so that's something to think about. This is why we're so aggressive with stopping bleeding, is because it's time sensitive. Not only because eventually it'll kill you, but what type of shock or is the patient going to experience from bleeding? And so in the hypoperfusion or lack of perfusion to these important tissues like the kidneys, brain, heart, lungs, can cause lifelong disorders. So, but I think that we're pretty good about obviously identifying bright red blood with external bleeding, but internal hemorrhage is probably just as, if not more common, and incredibly fatal because it's hidden. And so this is where we have to use intuition and clinical judgment and a good history and physical exam. We'll talk about how we identify internal hemorrhage through exam and in history. And so, it should be no surprise that the losing blood can cause weakness, shock, and death. Okay. Now, this is just jumping straight into the pathophysiology of it, of perfusion. So what is perfusion, right? It's the circulation of blood within an organ or tissue in adequate amounts. So this is basically when cells get the right amount of oxygen and blood and glucose and nutrients that they need, they're perfused. And when they're perfused, they do their job. So if it's your heart cell, it contracts. If it's your hair cell, it grows hair. If it's your eyeball cell, it does movement or whatever part of the eye we're talking about. But what I'm saying is cells have to be perfused to do their job. And I've hit this really hard in previous chapters, but certain cells absolutely require a lot more perfusion before they die or stop doing their job. So you could quickly name off the brain is very perfusion dependent. If it doesn't get its blood and oxygen and glucose, it stops working. And so we end up with altered mental status or decreased level of consciousness or more. And so this is why we see altered mental status and shock, is because the brain's not being perfused. And so that brings us to our next definition of hypoperfusion. Remember, the word shock simply means hypoperfusion. Hypo means below, so it's being below perfused. It's being less perfused. And so the cardiovascular system fails to provide sufficient circulation for body parts to function. And so, as we know, shock can take place in many different ways, whether it's obstructive shock or hemorrhagic shock or hypovolemic shock or distributive shock, the neurogenic shock, psychogenic shock, the list goes on and on. But here, when we're talking about blood, you're really kind of looking at two things, and that's going to be hemorrhagic shock, where you're literally hemorrhaging and losing blood. Hemorrhage is the medical word for bleeding. And you can also see this with hypovolemic shock, which is also like, you can lose volume by losing blood. And so that's a form of hypovolemic shock. The other form of hypovolemic shock is someone with vomiting, diarrhea, sweating, lack of fluid intake. So they're hypovolemic, meaning they don't have enough volume. Okay. And so these present similarly clinically as far as like the vital signs and what we would look for, but I'll draw some things out here for us. So remember, blood's coming out of the heart, the left side of the heart, through the aorta, and down into artery. Arteries are bigger, and then into our arterioles. And so these arterioles actually is where most of the muscle that you think of that lies within vessels, it's in the arterioles. And so this is where the clamping tends to take place. And so this has like a big change on your peripheral vascular resistance is in arterioles. And so remember, it goes artery, arterioles, and then the capillaries. The capillaries is the junction between the arteries and the veins. So this is where kind of blood just oozes across these membranes into cells, and carbon dioxide and oxygen is taking place through simple diffusion, and then it'll pick it up and then move it out towards the venules and then the veins. Now, some important concepts to get down is I would ask you, student, where does the majority of our blood sit? Right? Where is it at? Like at this exact moment watching this video, is it sitting in the arteries? Is it sitting in the capillaries? Is it sitting in the veins? Is it sitting inside cells? Is it sitting in your lungs? Where is it sitting? Right? And the answer to this is maybe a little bit surprising, but the majority of your blood is sitting in the veins. The reason for that is if I were to draw an artery, they have very rigid walls, right? And so the size of an artery is the size of an artery. It's just what they are. They're like water hoses. They're hard, and relatively speaking, and compared to a vein looks like this. And so it's filled with blood. Whoops. And so it's filled with blood, and so there's a lot of blood sitting in veins. But the reason that the majority of our blood sits in veins is they're a lot more soft. And so they'll go from this size to this size pretty easily, which means they have increased capacitance. They can have more capacity. So they can go from this little oval shape to this very easily. So they'll plump up. And so, your vein can go from looking like that to looking like this pretty easily. And so that is the idea, that veins have an increased capacitance. They can hold a lot more blood. And so we use this to our advantage with nitroglycerin and other drugs like that. But I'm just trying to point this out because I think students get lost on that. Now, obviously, emergency medical care in response to hemorrhage, you have to worry about, again, these very perfusion-dependent tissues, i.e. the heart, the brain, the lungs, the kidneys. I talk about these things all the time because they demand oxygen and glucose and blood and nutrients to be delivered to them. And if they don't get that, they die rather quickly. And, really, with the exception of the kidneys and lungs, I guess, if these tissues get damaged from hypoperfusion, they can have very lasting effects, especially in the heart and the brain, right? These cells don't regenerate. And so if you lose 2 liters of blood and you end up with like a heart damage or brain damage, that's it. Like, you don't get better from there. Like, it's not going to get better. So this is why we have heart failure for life if you end up with heart failure. And so this is why, we need to stop the bleeding and be aggressive with hemorrhage control and identify it and be aggressive in our treatments because of this reason. When these cells get damaged from shock, hyperperfusion, in this case, losing blood, there's lifelong consequences of this, okay? Now, we get into some pretty interesting pathophysiology this should be a review from the human body and the physiology chapter we've covered, but let's talk about it. So we'll just start with this word, the cardiac cycle, okay? What does that sound like? Cardiac meaning the heart cycles, and you should know this. The heart cycles from the minute you're born to the minute you die, 60 to 100 times a minute for life. And so it's going through this cycle. It's repetitive and it's pumping. And if it stops, you die. And so let me just read this to you. It begins with the onset of cardiac muscle contraction and ends with the beginning of the next contraction. So that's essentially from one beat, opening up, diastole, filling, to the next beat, squeezing. That's a cycle. And so you measure from one beat to the next beat. So, or you can measure, in layman's term, from one pulse beat to the next pulse beat. That's a cycle. So what all is happening within the cycle is things that we talk about with like preload and afterload and peripheral vascular resistance. But this is valuable stuff, and I test you on this, so it's worth knowing. So what is preload? I mean, break down this word, preload. So if you're loading something into something, you're loading bricks into a truck or hay into a trailer or whatever, you're loading it, okay? And so to preload is at the beginning of the load. And so if I were to draw the heart like this, preload is how much blood is sitting down here as the heart's opened, right? During diastole, right? When the heart is relaxed, how much blood can you get into the right side of the heart? And so this is a measurement, okay? And so we can increase preload by increasing the amount of blood in the system or amount of fluid in the system even. So at the paramedic level, we'll give them IV fluids, and I can certainly, by dumping fluid straight into a vein over here, right, I can dump it into the right side of the heart. Okay, so that's one way we can increase preload. And so preload is the amount of blood returned to the heart before the contraction. So that whatever's in here, let's just make up a number, 100 milliliters, it's going to get pumped out. And so that's preload. And so you can appreciate If I have 100 milliliters of blood sitting in the right side of the heart, um, and I pump almost all of it out, let's just say it's 100% out, like we just pump 100 milliliters out, that's a pretty good stroke, like it's a pretty good volume you're moving. But let's say you have had diarrhea and vomiting and sweating for the last week and you were dehydrated, and let's just say only 50 milliliters of blood get to the right side of that heart because you're hypovolemic, right? You can appreciate that you're going to have a lot less stroke volume. You're going to be pushing a lot less blood through the system because you have decreased preload. And so this is the idea of preload. When you hear preload, you should think how much blood is in the right side of the heart right before it contracts. That's preload, okay? And then there's this other thing, quite literally the opposite, called afterload. And so afterload, I'll just read this, is pressure in the aorta or the peripheral vascular resistance against which the left ventricle must pump blood out, okay? And so we know from the human body that the left side of the heart has to pump blood up and out through the aorta, okay? And so the aorta goes to all these different branches. And so, to remember, these arterioles and arteries can squeeze down, and that creates something called peripheral vascular resistance. Break down that word, peripheral, meaning in the periphery, and then that the vessels are resisting. So how much are they clamped down? And so that's peripheral vascular resistance. And so afterload is basically, the top number of the blood pressure. How much are you pushing against? How much does the left heart, how hard does that have to pump to get blood ejected from the left side of the heart out to the body? And so that is afterload. And so, I could recapitulate, the heart opens up, right? And then how much fluid's in here? That's preload. And then as it squeezes, how hard it has to squeeze to pump blood out and how much it squeezes out, that's afterload. And there's ways that you can influence these with medicines and interventions and stuff like that. But these are pretty common terms that get thrown around, especially in pharmacodynamics and therapeutics, to where you would want to know what these words are because they will show up on quizzes and probably exams, okay? Now, stroke volume, it's a very simple formula. I hate formulas, believe it or not. I'm not a math guy. Not every guy that wears glasses likes math, but I don't like math, but this is an easy one because it's intuitive, right? And so this is basically the amount of blood ejected per contraction, okay? And so I can tell you this is around, I think the number's like around 250 to 350 milliliters of blood per stroke. Now, I may be making that, I think that's wrong, actually. I'd have to look it up. I don't remember the number. But I think that may be minute volume. I'd have to look it up. Anyways, stroke volume is it makes sense. When the heart makes a stroke, it contracts. How much are you ejecting out of the ventricle? Now, actually, I can explain this easier. You would think that when the heart contracts, right, this is the ventricles, that it would squeeze completely shut and eject 100% of that. In reality, it really doesn't. It ejects around like 80-ish% in a healthy person, okay? In heart failure, that number goes down to like the 30s or 40s or even 20%, okay? Meaning that when their heart contracts, it's just going like this. It's not really ejecting a lot of blood because the muscle's weak. But a normal person, you eject like this. You're almost completely closing, you're getting around 80% of the blood out. And so that's stroke volume. And so we use this measurement really in heart failure to say like, okay, if it's less than 35%, you need to do this intervention or add this drug or do this surgery or whatever. But that's something to kind of be aware of, okay? Now, the cardiac cycle is connected to bleeding and shock through its relationship to blood pressure. And so this whole afterload, preload thing plays into blood pressure. And so as peripheral vascular resistance, meaning the outside vessels, as they squeeze down, that'll increase your blood pressure, mainly the systolic number, because this is measuring how hard do you have to squeeze systole to eject blood. And so, that's kind of what your top number is giving you on the blood pressure. So like the 120/80, I'm talking about the 120 number. Pardon me. Now, delivery oxygen to the tissues is dependent on an adequate heart rate, stroke volume, hemoglobin levels, and arterial oxygen saturation. And so this just shows you that there's a reason they call this the cardiovascular system. It's a system of systems that work together, including the heart and the lungs and the arteries and the blood. And this is all in a big system. And so a few things that we haven't hit yet in this meandering discussion is hemoglobin levels. And remember, hemoglobin is the substance in within red blood cells that carries oxygen itself. And so I would ask you, student, who has low hemoglobin levels? And you would answer, Hunter. It is the people that have blood loss for whatever reason, or you could even say it's the people that are iron deficient. Remember, iron is required to make blood, hemoglobin. And so you see this most commonly in the United States. We see people with low hemoglobin levels are menstruating women. Okay, so women that menstruate a lot, have a lot of blood during their periods, lose a lot of blood during their periods, their hemoglobin levels will drop because every month, especially if they have pathology and they have heavy flow during their period, they're losing hemoglobin, they're losing blood. And so they're losing it quicker than their body can produce it. And so that's just something to be aware of, okay? And arterial oxygen saturation, this is intuitive. The blood has to make its way to the lungs have to be functioning and bringing oxygen in and out to diffuse the hemoglobin to then deliver it to the cells, okay? Now, hemorrhage is a discharge of blood from the blood vessels. Remember, this can be both internal and external. So remember, simply put, hemorrhage is and word shows up a lot, that hemorrhage word. It is simply the word for bleeding. There's someone who is bleeding, inside or out, okay? The bleeding can range from a nicked capillary to severely spurting artery. We'll talk about what these look like, but external bleeding can be controlled by, and I talk about this a lot in our Stop the Leak course. You have all these tools in your toolbox. You can use direct pressure, pressure dressings. I wouldn't say splints sometimes. Hemostatic dressings, tourniquets, pressure bandage, wound packing, right? You have all these tools in your toolbox to stop the bleeding. So we'll talk about that in class a lot more and with exactly how to do this. But this is an important slide because I've seen this show up on exams. And so I would ask you, what type of bleeding does this look like, right? It's spurting blood across the post office, right? Rhythmic, like it's shooting blood rhythmically, right? That's arterial bleeding. It's literally shooting blood with each heartbeat. And so the first time you see this, you won't ever forget it because it's like the movies. It is shooting blood with each pulse. And so that is arterial bleeding. And so this is going to require direct pressure and or a tourniquet. Okay, probably a tourniquet to stop it even quicker. And so how this will be described on exams is blood that is spurting or shooting in a direction, or large amounts of spurting or pulsatile blood flow, right? Those are different words they could use to describe arterial bleeding. Now, this middle one is venous bleeding. And so veins are fairly low pressure, but they do bleed, okay? So this is venous bleeding, again, can bleed a lot, but it's not going to be spurting or shooting blood, but they can bleed a lot. And so they may say, that this is bleeding from the arm that is soaking pads, but it's not spurting, right? And so, or soaking gauze or something like that. I've seen them use the word soaking to describe venous bleeding, okay? And then this last one is capillary bleeding. So all the way down on the tip of your fingers, when we check blood glucose, this is the capillaries, the capillary beds where there's junctions between the arterioles and the venules, and they join, right? And so this is capillary bleeding, and this is what they'll refer to as oozing blood. Okay, it's just very little amount of blood. And so if you've ever checked someone's blood glucose or had a paper cut or something to that effect, you've seen capillary bleeding. Okay. So what I'm saying is sometimes you'll see this tested on exams. They'll describe one of these scenarios and say, what type of vessel is likely injured, right? And you would say have to know based on the description of what they're saying of what was injured. So obviously pay attention to the body part too. If someone says they've nicked or they cut the top of their finger off, right, and it's oozing blood, it's probably capillary. If they say they've been, they slit their wrist with a razor blade and it's shooting blood, it's probably going to be, arterial blood flow. So again, so that's external hemorrhage, and we're going to come back to external hemorrhage. But let's talk about the word internal hemorrhage, meaning inside of the body hemorrhage. And so this can appear anywhere in the body, right? This could appear in your eyes, in your mouth, in your brain, in your ears, in your neck, in your chest, in your abdomen, in your guts, in your bladder, in your kidneys. I mean, literally anywhere. It can appear in your muscle. So anywhere inside the body, this can occur, okay? And so these can be from trauma. Let me start with that. It can be from trauma. So yes, if I took a baseball bat and hit you in the deltoid with it or the bicep, you're going to bleed up underneath your skin. That is technically internal hemorrhage. But this can happen from non-traumatic, okay? So like GI bleeding, okay? So someone has an ulcer or a cut in their intestines, that can cause bleeding, okay? Or ruptured ectopic pregnancies. We talked about this in one of the previous chapters, right? So you get basically a baby that starts growing outside of the uterus, usually in the fallopian tubes and the ampulla, and it'll grow and grow and grow until that tube explodes, and so they bleed. Ruptured aneurysms. What's an aneurysm? So if I were to draw an artery, this is an aneurysm. This is like a ballooning. And so if blood's flowing this way, what happens is blood will get turbulent in here. And so eventually this can rupture, basically. This balloon the walls of this become larger and larger and larger. Imagine blowing on a balloon until it gets bigger and bigger and bigger and it pops. It because the walls get so thin. That can happen anywhere in your body. The most hallmark place you can get an aneurysm, a ruptured aneurysm, is in the brain or in the chest. That's the most common, or even in the kidneys. But that's the most common ones. Usually the head is where we notice it the most. Or other conditions. Let me talk about like what about like heavy menstrual flow, uterine cancer, ovarian cancer, endometriosis, or whatever. But you see a lot of bleeding disorder with women related to obstetrics and gynecology. Okay, so just be aware of that. Now, um, again, these can happen from non-traumatic causes, and that's probably some of the more common causes that we tend to miss. But it can, of course, this is why we have that whole index of suspicion. Oh, wow, this person just took a steering wheel to the chest and abdomen at 80 miles an hour when they hit a tree head on. So yeah, we need to be thinking, oh, there might be injury to the chest or the abdomen. And so this can happen from automobile collisions, blast injuries, falls, all those things, any type of traumatic injury. And this is why we use the mechanism of injury to be suspicious of like, oh, you took blunt trauma to the abdomen. There could and very likely is bleeding within the abdomen, internal bleeding. And so the nature of illness for internal bleeding. So again, bleeding ulcers, bleeding from the colon, ruptured ectopic pregnancy, aneurysms. Those are all possible causes. There's more than that, obviously. But signs and symptoms of internal bleeding is usually, interestingly, it's going to be pain. We have this lining inside our intestine, inside our frontal abdominal cavity called the peritoneum. And when it comes in contact with blood, it gets inflamed and it causes a condition known as peritonitis, meaning inflammation of the peritoneum. So it's extremely painful. And so your patient will be complaining of abdominal pain and guarding. So if you try to press on their abdomen, they're going to be flexing their abs to where you can't really push on that because it causes pain. Okay. Again, you could get swelling or distension of this bleeding area. Again, we're talking about like the abdomen or even in the arm, like a bruise. If I were to frog you in your arm and you get a bruise, right, that's internal bleeding. That's bleeding up underneath the skin. And so you could get distension, bruising. Now, in large bleeding, you can get shortness of breath, tachycardia, hypotension. Those are all shock signs, hypoperfusion. Hematoma, this is a word you'll see a lot that you need to be familiar with. This is the medical word for a bruise, okay? Hemat, right, that means blood. And so oma means like a mass. And so it literally means like a mass of blood. And so you can get a mass of blood under the skin, and we call that a bruise in layman's term, okay? Other signs and symptoms, so you get hematuria. This is blood in your urine. You need to know these words show up on exams, and it throws students off. So do know these words. You should probably already know them from medical terminology. But hematuria means blood in the urine, okay? Hematoemesis means you are vomiting blood. Hemoptysis means you are coughing blood. Melena or melena, both of them are acceptable. It means you're pooping blood that looks like tar, like road tar, like black, and it's sticky and it stinks incredibly bad. And hematochezia is where you're pooping blood. Okay, this is like poop with streaks of blood in it. Okay, this is poop and blood mixed together, not just frank blood. Frank blood, if someone's being frank with you, they're being obvious. Frank blood is just obviously blood, so you can't just poop frank blood, and it's not even poop really. It's just blood. Okay. So the first sign is generally a change in mental status. Why is that? The brain needs perfusion. It's not perfused. You get altered mental status. So substantial changes in vital signs occur for approximately 2 pints of or 1 liter of blood loss. I don't have my Evian water today, but this is like, okay, yeah. I mean, it's a fairly large amount. So it's 2 of these, a little less than 2 water bottles is a liter. And so you've seen, the Evian water bottles or a liter of IV fluid or something like that. That's a substantial amount of blood loss. So I would tell you, student, there's like 5 in a normal adult. There's like 5 to 6 liters of blood in the whole human body, right? So if you were to completely wring out a human and take all their blood out, it's around 5 to 6 liters. But a better question is, how much blood could you lose prior to having altered mental status or shock or organ tissue damage or whatever the issue is? So that's something to think about, okay? Hemorrhagic shock results in inadequate perfusion and eventually it'll lead to death. Okay, so again, this is where we have to consider the significant mechanism of injury, like a baseball bat to the abdomen, or a steering wheel to the chest, or whatever the scenario, a fall from 30 feet. You have to be worrying about like the mechanism of injury for those hidden internal bleeding injuries that we can't immediately see with our eyes. So these patients could have poor general appearance. And so they could have what we call diaphoresis and pallor, which is where they're pale in color and a little bit sweaty, cool to the touch. These are all signs of shock. Signs and symptoms of shock: rapid blood loss, uncontrollable bleeding, right? So Anyways, the physiological response to hemorrhage is interesting, right? So we have internal clotting mechanisms that should work. And this is a part of a thing called the clotting cascade. And so it's a series of events that have to take place with all these like proteins and enzymes that will eventually stop bleeding. And so, you've experienced this with a bloody nose. And so if you were to pinch your nose properly and you have a bloody nose, it should stop bleeding in 5, 6, 7, 8, maybe 9 to 10 minutes, okay? 5 to 10 minutes. Um, but you know that every time you like blow your nose and that you restart, you blow that clot off, right? The clotting cascade has to restart. And so this is the important part of like when we apply pressure or we're trying to stop bleeding is that it's continuous pressure because the clotting cascade on a good day takes 5 to 10 minutes, okay? And so this is an important thing to know. And then the process of this clotting cascade to get to where blood will clot has a word that sounds familiar, but it's a little different. It's called hemostasis, not homeostasis, which is the balance of life. This is called hemo, meaning blood, stasis. This is platelets plug the hole and seal the injured portions of the vessel. And so hemostasis is essentially like clotting off, clotting like a bleed. Okay. Now, uh, old people take medicine that a lot of old people actually take medicine that interferes with bleeding. They take blood thinners, basically. And so you don't need to memorize these names, but drugs like Apaxivans, Xarelto, Eliquis, Lovenox, heparin, warfarin, right? All these drugs that are blood thinners, true blood thinners, that actually interfere with the clotting cascade to make blood more difficult to clot. Because if someone has clots that are likely to form in their head or in their heart or their lungs, we give them these medicines to where they don't form clots because that keeps them alive. But the problem is when they fall and they bang their head or they're in a really bad car wreck and they're taking these blood thinners, you really have to start worrying about internal bleeding or external hemorrhage, even getting it controlled because they're going to bleed and bleed and bleed because they are taking a medication that's causing them to not clot. And so that's something that we would want to get in a good history with all their medications. And so again, you would want to watch out for those medicines like Xarelto, Eliquis, Apaxaban, Lovenox, all those other drugs. There's a lot of them. And so just be aware of that, that old people, namely, will take these blood clotting these blood thinners that will make them not clot. And so, the example, another example is like, oh, old lady's pooping bright red blood, but she's taking Eliquis, right, for her AFib. You're like, oh gosh, this is a true emergency now because she's going to keep bleeding. So you have to the surgeon usually have to go do something to fix this. Now, a patient with hemophilia, remember this word, these are males, almost always males because it's X-linked recessive, that have a blood clotting disorder where they will continue to bleed. It's almost like they're taking blood thinners every day, but they're not. It's a genetic disorder. And so this is almost only men that will get this disorder, but it can be fatal, okay, because they will bleed and bleed and bleed and bleed. Now, there are medicines at the hospital you can give to try to, usually they can try to stop the bleeding, but that's something to keep in mind. Hemophilias are at, if they're bleeding, you got to get them to the hospital. You can't stop it. Even with that's the problem with like blood thinners and like people that have hemophilia, patients that have hemophilia, is even with direct pressure, they will continue to bleed. And so because they don't have the things required in their blood to form clots or good clots. And so that's just something to keep in mind. Now, we've talked about this in previous chapters. It's actually the last chapter called the trauma triad of death. Ooh, sounds scary. Sounds like a tattoo. But it's a combination of hypothermia. Remember, hypothermia means low thermo, right? So low temperature. Coagulopathy, which means pathology of coagulation, right? And acidosis, which increases mortality. So this is why we keep patients warm and we keep them ventilated and we transport them to the hospital rapidly, okay? Coagulopathy can result in further hemorrhage. So for example, like a patient with what's it called? Hemophilia or with DIC, that's coagulopathy, right? Disseminated intravascular coagulopathy. It's literally in the diagnosis. They're going to continue to hemorrhage, and so this is just something to keep in mind. And so this is why some of our more sought after treatments for bleeding is to keep the patient warm and to rapidly transport them and to prevent acidosis. Okay. Now, this is important. The scene size up. Be careful with the bleeding. Sometimes examiners will trick you, and they'll say like, "Oh, patient spurting blood, but she was stabbed in the neck." The attacker's it's not known where the attacker's at. What do you do, right? And so again, your safety. If an answer choice is there that says retreat to safety until law enforcement deems the scene safe, then you would. So again, watch for safety with these bleeding things. What they'll do is they'll trick you into rushing into an unsafe scene by giving you some dramatic story. Don't fall for it. Okay. If there's a question about you being safe or an answer choice about you being safe, choose it. It's usually right. Now, make sure the scene's safe. Take proper, appropriate standard precautions. You'll notice this guy's wearing a gown, mask, and goggles. If I knew, like for example, like you get dispatched to a priority one shooting, and I or childbirth or anything, and I knew I was going to be staging, meaning I was going to park down the road and wait for law enforcement to make the scene safe, or a stabbing or something to that effect. Um, I would get in the back of the ambulance and put on like a gown and a mask and goggles and everything. That way, when I got on scene, I was ready because you didn't want to get their nasty blood all over you. So just keep in mind when you're staging, waiting on law enforcement to make the scene safe, you could be putting on a mask and gown and a visor. Okay, so consider the need for additional resources. Now, you're going to search for life-threatening bleeding. Something the military does. I've taught this occasionally, called a blood sweep, where if the patient's just covered in blood, you don't know where it's coming from. You can put gloves on and just start feeling and look at your hands frequently, or feel to where when they come back wet, that may be where the blood's coming from. Okay, um, so look for life-threatening bleeding. Be aware of obvious signs of injury and distress. Perform a full body or full body scan of the patient. Now, keep in mind, when someone's bleeding, it's like motor oil, so it's like slippery and slimy, and it's scary and red. And so, be aware that um, someone could have like a very small injury potentially, and it's producing a large amount of blood. And so, you'd be thinking like, wow, there's a lot of blood, but I can't find out where it's coming from. That's what I'm saying. Sometimes it's kind of hard, especially when they're covered in blood, to find out where it's coming from. And then so we've known the mnemonic A B C D E, but they add this word X in there for exsanguination, and which basically means to bleed to death. And so they're saying if you have someone who's bleeding to death, you would stop the bleeding before you would do anything else. So you notice they throw this X in here now that says stop the bleeding, and then worry about their airway, breathing, circulation, disability, environment, all these things. So bleeding really does come first, because if they're shooting blood across the room, their airway's not going to really matter 30 seconds from now. They're going to die. And so you need to stop the bleeding. Determine the level of consciousness. We can use the AVPU score. Remember, alert, verbal, pain, unresponsive. And any internal bleeding must be treated promptly. Now, I would say it doesn't matter if you're a paramedic or even an ER doctor in the Chili's parking lot. Unless you're a trauma surgeon in an OR, you can't fix internal bleeding. That has to be done in the operating room. So that's something to keep in mind. So your treatment is quite literally rapid transport. Take them to the hospital so a trauma surgeon can fix them. Determine how fast the transport decision should be made and where the patient should be taken. Now, the history taken, investigate the chief complaint and be alert for signs and symptoms of other injuries due to the MOI and nature of injury. It's where we have that, quote, high index of suspicion based on the injury. Carefully assess the mechanism of injury in trauma patients. So again, this is where we do our detective work. How far did you fall? What did you fall on? What part of your body did you fall on first? If they're in a car wreck, were the airbags deployed? Were you wearing your seatbelt? How fast were you going? Are there skid marks? What does the damage to the vehicle look like? Were they entrapped? These are all things that we're looking for in injuries, okay, injury patterns. And then we obtain the OPQRST. Laura told me the I mnemonic, but I don't remember what it is. She told me last week. I don't remember. I never remember what the I mnemonic stands for. Anyway, secondary assessment, uncover injuries or illness that may have been missed. So remember, in our secondary assessment is where we kind of take a little bit of a deeper dive. We've addressed the airway, breathing, circulation complaints, stop the bleeding, and so we can dive a little bit deeper. And so this is where we can like really start getting deeper vital signs, and we can do respiratory, cardiac, neurologic, musculoskeletal exams. Right? We can really assess those because we've addressed immediate life threats. So this is where usually you're transporting to the hospital, you've done what you can do, and so we're going to start assessing and reassessing, okay? And obtain baseline vital signs, of course, and reassess. So if a patient has external or internal hemorrhage that is severe, we reassess the vital signs every 5 minutes, okay? And we're out to the ED. So I've seen students before, there will be an answer choice, like they paint this crazy bad scenario, the patient's definitely dying, very sick, and Students want to pick, you reassess vital signs every 1 minute. No, the answer is still every 5 minutes for critical patients. Okay. With internal bleedings, describe the MOI and NOI, and so you'd want to document that in your report, all those things. So like mechanism injury again, how fall did they fall, or how high did they fall from? What did they fall on? What part of the body did they hit first? Those things. Nature of illness. How long have they been pooping blood? Is it a large amount of blood? How many bowel movements have they had? Are they filling the bowl completely? Is it mixed with blood, right? Or is it mixed with poop? All these things, have this happened before? Do they have a history of hemorrhoids? All these issues that you want to dive into and be a detective to figure out what's truly going on. So external hemorrhage, this is external meaning outside, so the outside of the body. Now, external hemorrhage is very effective. And so 90, the majority, this is out of Stop the Bleed presentation, the majority of hemorrhage, even major arterial hemorrhage, can be controlled with direct pressure alone. So what I tell students and I tell EMTs and I say in my Stop the Bleed class and I tell paramedics or whoever wants to listen to me is in the absence of a tourniquet, when you don't have a tourniquet, let's say you're in Walmart off duty and someone's bleeding to death, just become really good at direct pressure. Direct pressure is very, very effective. And we'll talk about how to do this properly, but basically it's two hands pushing down with a lot of pressure and you don't take your hands off. So if my gauze gets saturated in blood, I put more gauze on top. That gets saturated, more gauze on top, because what's underneath on the skin level is a clot. And every time you lift that up and look or replace it, you're restarting this whole blood clot process, the clotting cascade. And we know that takes 5 to 10 minutes in a healthy person on a good day. And so that's something to be aware of, okay? Now, you can do a tourniquet if you have one. I'm a huge fan of tourniquets, but just be aware you're not always going to have a tourniquet. So if you don't have a true combat application tourniquet, like a real tourniquet, not your belt that you're trying to MacGyver with a belt and a stick, but a true tourniquet, just be really good at direct pressure. And so as these patients decompensate, you start getting blood loss, shock, hypoperfusion. You might see their oxygen saturations drop below 94%. That would be an indication for oxygen. And if, as they continue to die, they may stop breathing or not be breathing effectively. So we might have to assist their ventilations with positive pressure ventilations. Now, again, direct pressure is effective for most external bleeding. I cannot stress that enough. Don't let the movies lie to you. I'm telling you, if you don't have a tourniquet, become very effective at direct pressure. You're going to apply pressure on top of the bleeding site, and you're going to continue pressure until you're at the hospital, okay? If you are going to wrap it, you would want to stretch the bandage tight so you can get enough pressure on there. You can occasionally wrap if it's not like major bleeding, okay? Now, if direct pressure fails, you can consider applying a tourniquet or wound packing with a hemostatic agent. We'll show you in class, we have wound packing simulators, several different forms, where you can pack a wound and feel what that feels like to simulate it. Now, wound packing, we do wound packing in the torso-junctional areas. What does that mean? That means you can do wound packing in the shoulders, the groin, the hip, even the neck if you have to. But we don't do it in the abdomen or the chest because this is a huge compartment. And so you can pack all your gauze in the ambulance in the abdomen very easily, okay? And so hemostatic agents, these are basically gauzes that are enhanced with chemicals to speed up the bleeding or the clotting process. And so these aren't as common as they once were, but they are still out on the market. Cellox is a fairly common brand. Just be careful with this. You know, like back in the day where they had the powder, you can't even buy that on the market anymore. It's not used because someone has to go in there and clean that up and debris it, and patients are having bad outcomes. And so, but you do see hemostatic gauze occasionally on the market. It's just more expensive. It stinks, like it smells, and it expires quickly. And so that's why you don't see it as common. But good old gauze. You know, if you don't have gauze, use a shirt. Use whatever you got. A rag. Now, tourniquets, we put these on extremities. You can't put a tourniquet on the neck, or at least you shouldn't. And so these can go up on the extremities. There's a saying from the military called high and tight, where basically you just put, it doesn't matter if you're cut here or here or here. You just put a tourniquet up really high and make it tight. And so if I was cut here, the textbook will say you can put a tourniquet 2 to 3 fingers above it. So if I was cut here 2 to 3 fingers, which is 2 to 3 inches above it, I could put a tourniquet here and that would be correct. That's fine. But, you know, the high and tight methodology seems to work pretty fine. Okay. And so, you know, I wrote a large grant, like a $50,000 grant for Parker and Palo Pinto County to get Stop the Bleed equipment in all the schools. And we did that successfully. And so we used the CAP tourniquet. This is by far the most common. It's been truly combat tested. There's data supported its use. It's a superior product, premium product, easy to use, easy to train, and it's rigid, lasts a long time. So that's what we use. And it looks like this. This is a cat tourniquet. Okay. There's other ones out there. Some are better than others, but my personal opinion is the cat tourniquet is by far the most superior. It's easy to use. It's reliable. Now, one thing I will say is there's counterfeit products, so be careful buying these online. This should cost you around $30. If it's a $10 one off Amazon, it's probably going to break. I wouldn't recommend buying it. Now, this is um, if a commercial tourniquet is not available, you could technically use a triangular bandage and or a stick and rod. And so basically what you do is you put this into like a triangular bandage. Remember the thing we make the arm sling with? And you just twist and twist and twist. Now, we don't teach this to the layman's, like to normal people outside of medicine, because it's ineffective. This is not an effective way to do this. More than likely, direct pressure would control this better and take less time. The problem is you can usually get this tight, but how do you secure it and keep it tight? Someone has to hold it. And so this is just not my preference. Okay. So, but your book mentions it. Now, this is called a pelvic binder. When someone breaks their pelvis, first off, it's high energy. It takes a lot of energy, a lot of effort to break the pelvis. And so as it opens up, that's called an open book pelvic fracture. Sometimes you put this binder back on the pelvis to bring it back together, and it can help with the bleeding. So it's called the pelvic binder. We'll show you what this looks like in class. We have one in class. We carry them on the ambulance now. I've actually never used this on a live person, though. Now, these are cool. These have become very popular. These are called air splints. And so basically, it's like you can use these for a fracture, but the cool thing is it applies uniform pressure in a splint. You can see like her arm's wrapped in there, and you pump air in there, or in some cases you pump air out, and it will it'll make it rigid to where it splints it. So again, we'll show you these in class. But these are a good way to stop the bleeding, especially like on soft tissue injuries with like associated fractures. Now, we'll have to unfortunately show you these in class, but they're not used anymore. But occasionally these can show up on exams. These are not the standard of care anymore. But there's these things called pneumatic anti-shock garments, or PASG, okay? And I've never used these on a real person, but we do have a couple pair at the training center we'll show you, and we'll put them on and show you how to use them. And so basically what happens is it's a device that squeezes on your legs that can stop the bleeding, one, but it forces blood up from your legs up into your core. And so it's rarely used, but I thought I had a picture of them. I don't even have a picture of them. I thought I had a picture of them. We'll show you. So basically imagine like really big blood pressure cuffs that go all the way from your ankle up to your hip. And they squeeze really tight. And you like pump it up like a blood pressure cuff, and it forces the blood up into your chest. They're not used very often. But for whatever reason, they're still tested. So that's why we're talking about them. Now, there's this thing called the halo sign. It looks like this. Let me just show you. And so you can see how there's like a drop of blood here, and outside there's like this yellow ring, okay? That's called a halo sign, like a halo, like an angel wears, or Beyonce sings about a halo sign, right? And so that yellow ring is cerebrospinal fluid. So remember, the brain is coated with this fluid called CSF, cerebrospinal fluid. And so when you break the base of your skull, meaning this part, the base of the skull, it produces this thing called battle signs, which is where you'll get what am I talking about? Periorbital ecchymosis, right? Where you get bruising around the eyes, or raccoon eyes. Okay, that's what the literature will call it, raccoon eyes. If you've ever seen a raccoon, they have black eyes. And then you can get what's called, this is the battle signs part. This is where you get it, bruising behind the ear. So this is common with a basilar skull fracture. So if someone breaks this part of their skull, the bottom part, the base of their skull, usually from a crush injury, you'll get these, but you also get you could get CSF leaking through the ear. So how you do the halo sign is you take a piece of gauze, a clean piece of gauze, and you put it up to this lady's ear and you hold it there. And then eventually you'll take it back and you'll see that there's going to be blood. Of course, there's blood coming out of her ear, but there will be a white or like a yellowish ring around the blood. That's a positive halo sign, and that indicates that they've likely cracked the base of their skull, basilar skull fracture. And so I've seen this a few times where I've seen it, the guy was dead. This guy in Crescent was doing something up underneath the car. He had the wheel off. I think he was like changing the brakes or something. I don't know. And the vehicle fell off the jack, and so the frame of the front of the car where the motor was fell on this guy's face and just smushed it, like and concaved it. So his brother saw it happen, tried to get in the car off. It's kind of sad. It was very sad. And so what I'm getting at was it obviously smushed his skull. It cracked his skull, killed him, dead. And so when we got there, he actually did have the bruising behind the ears and the periorbital ecchymosis. And so what I'm getting at with this whole basilar skull fracture stuff, this bruise, I mean, think about it. If I were to slug you in your arm right now really hard, are you going to bruise immediately? Probably not. So when you see bruising in EMS, realize that's a late finding. So you'll see periorbital ecchymosis and bruising behind the ear called battle signs late in the finding. This one guy where the vehicle fell on his face, I did see it when we got there. You could see it immediately. It's probably because of how much blood was there. Like it exploded his skull, imploded it really. And so just be aware of that. Now, hemorrhage from the nose, ears, and mouth can be caused by a skull fracture, quite obviously. Facial injuries, so this could be from assaults, fights, motor vehicle collisions, falls. Sinusitis, infections, nose drop use, I don't know what that means, and abuse, dried or cracked nasal mucosa. So, of course, a benign nosebleed is fairly common. How do we stop that? You tell the patient to pinch their nostrils and lean forward. If you have them lean back, the blood will drip down their esophagus into their stomach. Blood is very irritating inside the stomach, so they will vomit if you get blood inside the stomach. So you want them just to lean forward, and they can spit out blood as it comes. Okay? High blood pressure, you can see people bleed from their nose and even within their eyes a little bit from high blood pressure. Coagulation disorder, digital trauma would be like your fingers. Okay? And so this is, again, that's a positive halo sign. So definitive care is obviously going to transport them to the ED. Treatment, minimizing shock, rapid transport. You can use ultrasound. When we look at babies on an ultrasound, to locate bleeding, that's usually unnecessary, but you can, especially in cases of internal hemorrhage. This is usually paramedics and physicians that'll do this that have additional training, but it is an option. Don't give the patient anything by mouth. This is an important point. When people are hypovolemic and or hemorrhagic, meaning they're bleeding to death, or even not even to death, they're just bleeding, their body will say, you're thirsty. You need more fluid because you're losing it. So you need to drink. And so you'll notice that they'll try to drink. So they'll say, I'm thirsty, I'm thirsty, I'm thirsty. And actually, that's quite ominous when you hear that. It's a bad sign. When the patient's begging for water, do not give it to them. There's several reasons for this. First off, they're likely to vomit it as they continue to die. It's not going to help them in the immediate term. From you putting water in your stomach and it truly getting absorbed is going to take longer than they have. And the most important part is when you start putting fluid in the mouth, they can vomit. And if they were to have surgery, you kind of increase the risk with surgery when you put fluid in the mouth or food in the mouth. So we don't give them anything to eat or drink, even if they beg for it. Keep the patient warm and monitor their vital signs. Now, the management of hemorrhagic shock is relatively intuitive. Stop the bleeding. Stop the bleeding, okay? And we're going to talk about this in our hour-long Stop the Bleed course with exactly how to do that. Take standard precautions, ensure the scene is safe, don't get trapped into the whole scene safety thing where you rush into an unsafe scene. Identify and stop any major bleeding. Now, I left this in here. I know this is an EMT course, but I want to talk about IV fluid because you've probably seen this or even thought about it. Now, we do give IV fluid occasionally in hemorrhage, okay? As paramedics or physicians or whatever, you'll give IV fluid occasionally, but not too much. You can dilute the blood. So imagine you have like really rich, delicious Kool-Aid, and I keep pouring just water into it. That's dilution. The Kool-Aid's not as strong. Well, the same thing happens in the blood. You have really good normal blood, but you keep dumping IV fluid in the water, the blood in the water, or the blood in the fluids dilute. So it becomes like, instead of red blood, kind of pinkish blood. It's not as strong. It's not as effective. So there's risk of giving a bunch of IV fluid during hemorrhage. And my next very important point is I would ask you, student, does normal saline, right, the stuff that we give in IV fluids, does it carry oxygen? It does not. It's not hemoglobin. So you still run the risk of if you flood someone with fluid in their veins, it doesn't carry oxygen and they're losing their hemoglobin through their blood loss. So sometimes IV fluids truly can cause more harm than good. And so this is a paradigm shift of what we used to do. The central dogma Years ago, probably even 5, 10 years ago, was give everyone tons of IV fluids. But now we don't. We hold off on IV fluids in cases of major hemorrhage because of the dilutional effect, because of the acidosis associated with normal saline, because of the fact it doesn't carry, it doesn't have hemoglobin, so it doesn't carry oxygen. So there is harm that can be done by giving IV fluid to a patient who is bleeding to death. Now, last line just kind of drives home. They're going to say the IV fluids are the treatment, and really they are, because it may be the only option you have. The real treatment is to stop the bleeding, transport, keep them warm, and replace the blood if necessary. And at the Parker County Hospital District, we do carry blood, and so they do get blood. But you would want to monitor the level of consciousness, pulse, blood pressure, capillary refill, mental status, capnography, temperature. You're going to closely monitor the patient throughout transport because the risk of them getting worse is fairly high, especially if it's internal bleeding where you can't stop it. So I know this is quick and we didn't talk a lot about the treatment of stop the bleed, but realize, students, again, in the description of this video, I'm going to link my stop the bleed video, and we are going to have a full stop the bleed course in class where you'll get to apply tourniquets to yourself and your partners and do wound packing and simulators and direct pressure on simulators and all these things. So we will do that in class. So with that, I appreciate your time.